Hello ladies and gentlemen, welcome back to our ongoing series of lectures on anesthesiology. Today we are going to talk about epidural analgesia. We discuss in this lecture drug and dose, site of insertion, techniques, advantages, complications. So let's go to start our lecture. Epidural analgesia. Epidural block is popular for post-operative analgesia because of familiarity with the technique and ease of insertion of a catheter. Epidural analgesic techniques can provide superior postoperative analgesia and modify physiological changes associated with some forms of surgery. Postoperative epidural analgesia can reduce the incidence of pulmonary morbidity. However, epidural techniques also have uncommon but serious risks attached to catheter insertion and removal. For example, epidural hematoma and risk-benefit ratio for each patient must be considered. Drug and dose. Repeated injections may be made through the catheter or a dilute solution of local anesthetic infused continuously, usually 0.1 or 0.125%. Initially, bupivacaine produces analgesia lasting up to 4 hours, but by 24 to 48 hours, some tolerance develops and single bolus administrations may last for only 2 hours. Ropivacaine, in low doses, may offer the advantage of producing similar sensory block with less motor impairment. Levobupivacaine produces local anesthetic effects similar of those bupivacaine. Site of insertion. Bupivacaine 0.25% injected at L2 or 3 provides good analgesia after lower abdominal or perineal surgery, for example, hysterectomy or transurethral resection of prostate. Upper abdominal procedures require a higher block, performed usually in the lower thoracic spine. For thoracic surgery, an epidural catheter may be inserted in the thoracic region between T6 and T8, and volumes of bupivacaine of 6 to 12 milliliters may provide excellent postoperative analgesia. Techniques. Epidural catheter techniques should be used only when the patient is nursed in a high-depending unit, because of the risks of hypotension after epidural injections and total spinal block if the catheter migrate into the subarachnoid space. Continuous infusion epidural techniques are managed on general wards, but adequate medical and nursing staff training and experience support are needed. Advantages. Superior pain relief. Starting analgesia before surgical incision may reduce postoperative pain by decreasing nervous system sensitization. Improve postoperative respiratory function. Reduction in the stress response to surgery after lower abdominal and lower limb surgery. Reduction in the hypercoagulable state after major surgery. There are decreased incidence of deep venous thrombosis and pulmonary embolism after hip surgery. Reduced intraoperative blood loss during surgery on the lower part of the body. Improve postoperative gut function, facilitating early internal nutrition. Earlier ambulation and potentially reduced hospital stay. Several studies have indicated improved quality of life postoperatively compared with IV patient-controlled analgesia. Complications. Dural puncture, 0.6 to 1.3%. Epidural hematoma, the risk is increased by impaired hemostasis when the catheter is inserted or removed. Guidelines must be followed for concomitant prophylactic low molecular weight heparin. Epidural abscess, meningitis % direct neurological damage. Systemic local anesthetic toxicity. Total spinal anesthesia. Sympathetic blockade, urinary retention and motor block.
Thanks for watching. Anesthesia with Dr. T.